guys know in my last meeting,
Oh,
I my Zoom sort of froze a couple times in my last meeting. So if that happens, if I hopefully I notice and I'll just turn my camera off. It seems to help.
okay. All right. Thank you. It's good to
Okay.
have a heads up.
Well, I'll start letting people in now.
Perfect. Thanks, Rahel. Well, welcome everyone. We have folks coming through cyberspace here. So we'll give everyone a minute to come in from the waiting room and join us. But thank you all for being here today as we're talking about building a diverse and equitable oral health workforce. Joined here by Miranda Davis, who we'll hear from shortly. Looks like we still have some folks coming in, but we'll jump in and get started to make sure we stay on time here. So we can head to the next slide. So today we are going to go through a welcome and housekeeping. Again, we're talking about building a diverse and equitable oral health workforce. We'll have Q&A and there'll be some community collaboration and discussion built in throughout the session today. And to introduce myself, I'm Liz Flannery. I use she, her pronouns. I'm the Director of Education and Leadership here at AIDPH. So welcome again, everyone. We can head to the next slide. We want to say thank you to our partners, UNLV, NRHA, the Open Network, and Southern Plains Tribal Health Board for making this program possible this year. And head to the next slide. So just some housekeeping notes. We are recording this session and we will post the recording and the materials to our website after the session. All of the materials will be available on our website as well as our Academy platform. Please make sure not to share any patient information. Be sure that you're sticking to privacy rules as we have community discussion here today. I invite everyone to type your email and organization into the chat and introduce yourself. Again, a big part of this presentation today is going to be community discussion and collaboration. We'll have some time for some chat discussion as well as some time for some group discussion. So let's get started on saying hello to each other and get ready for that collaboration. If you're having any technical issues with Zoom, please pop that in the chat and we can help you with from the AIDPH staff. We can head to the next slide. Excuse me, thank you. So I'm just going to give you a little bit more information about American Institute of Dental Public Health and who we are and why we're here today. Our mission is to empower our community to advance oral health through science, education, and advocacy. And we're doing that because our vision is a justice-oriented oral health system. So the programmings, like this education program here that we're doing here today, move us towards that vision of working towards justice in our oral health system. We can head to the next slide. We have 4 communities of focus at AIDPH, which include LGBTQIA+ people, veterans, people with disabilities, and of course, rural communities, which is part of what we're focusing on here today. Go to the next slide. This is a graphic of our academy, which I referenced earlier in the call. This is an overview of the offerings that we have at AIDPH through our education and leadership team. Our goal is to have a really diverse set of offerings so that all dental public health professionals have something that fits their needs and their schedules. We have things like this program here today that's a certificate program. Folks can participate in one session or they can participate in the entire series, take some quizzes and earn a certificate in the focus area. We have sessions that are more one-off workshops, webinars, all the way up to our in-person colloquium. If you ever have any questions about that, please feel free to ask us. Can head to the next slide. These are our session norms. We want to make sure that everyone learns and everyone teaches. We use first names to facilitate equality in the discussion. We invite you to add your pronouns to your Zoom name. Again, introduce yourself. I see folks doing that in the chat, so thank you for jumping in and starting up that community collaboration. And we ask that everyone limit their environmental distractions. So we understand some folks might not be able to, but we invite you all to turn on your video to be engaged, especially when we come to those discussion portions. You can head to the next slide. Okay, so our focus this year is navigating rural and tribal oral health solutions using a community compass. So we have this focus to explore key assets of rural and tribal communities and how to advance oral health access through community engagement. This is building on last year's sessions that focused on innovations in rural oral health, which there is also a certificate available for, although it's not a prerequisite to participate in this year's certificate. We offer CEUs for all of our sessions. We'll post information about that at the end. It's required to attend the entire session live to be eligible for that CEU. We'll share the evaluation and request link for that at the end of the session. Can head to the next slide. So again, these are our topics. Today we're talking about building a diverse and equitable oral health workforce. We have 2 more sessions that will come up in October and December later this year. So we just want to give a note to keep an eye out for future sessions as well. You can head to the next slide. These are our learning objectives. These were included in the registration information and are attached to our CEU process. You can head to the next slide. And our presenters do not have any disclosures. You can head to the next slide. So I have the distinct pleasure of handing it over now to Dr. Miranda Davis. I'm just going to give some information about her background before she jumps into her presentation. We are so lucky to have her with us here today. Miranda directs the Northwest Dental Health Aide, which DHA program at the Northwest Portland Area Indian Health Board, which assists tribes in Washington, Oregon, and Idaho as they incorporate dental therapists and other types of dental health aides into their communities. And Dr. Davis also serves as the prevention consultant for the Northwest Tribal Dental Support Center, serving the 43 tribes of Washington, Oregon, and Idaho. She also has provided clinical care for tribes in the Northwest for 17 years, in private practice for 5 years, and has served as a volunteer in 9 countries. She's very passionate about public health and believes everyone deserves to have access to high quality oral health care, which I think we all do. So cheers to that. Thank you, Dr. Davis, for being with us here today. And without further ado, I'm going to hand it over to you to go through your presentation.
Thank you so much, Liz. And it's great to see so many familiar names in this group. I'm honored to be able to be here today to tell you about the work that we're doing at Northwest Portland Area Indian Health Board. And it's just always fun to be in a group of like-minded individuals that care about dental public health, as I know you all do. So we'll go to the next slide. I start by just telling you a little more about the organization that I am so honored to work with. Northwest Portland Area Indian Health Board is a nonprofit tribal advisory organization. We serve the 43 federally recognized tribes of Oregon, Washington, and Idaho. So that's the region that I'm honored to support in this work. And our work is directed very directly by our board. Our board is comprised of a delegate from each of the tribes that we serve. And so essentially, the people directing all the work that we're doing are delegates from the tribes themselves. So all of our work is directed by the communities that we serve, which is just such an exciting place to be. I will go, I should let you know that within our 43 tribes, there are 39 dental clinics. Some tribes don't have a dental clinic. Some tribes have more than one dental clinic. We also serve the urban Indian health programs in our region. So that's counted in that number. So it's a good variety. Yeah, so we can go to the next slide. So we look a lot, as you can imagine, at the barriers to receiving healthcare for all of our tribal communities. But as you know, and this is rural health focused, there are some unique challenges to rural healthcare. And so some of the barriers we see are these ones listed here, and we'll talk a little bit more in a discussion in a minute. We see barriers related to distance, providers, trust, historical trauma, other trauma. People have competing priorities for, between having to go to work and having to go to healthcare appointments and so many other things, childcare. And we really are focusing right now on meeting people where they are so that we can help make sure they're getting the care that they need. But what does that mean? It means a lot of different things, as all of you who work in this space know. And one of the main solutions that we're looking at, because it's just such an important piece of the puzzle is that rural healthcare workforce and how we can build that workforce to provide the support that people need and provide the care that people need, where they need it, when they need it, how they need it. And so we'll move to the next slide where we would like you all to kind of contribute to this, because I know I don't know everything about everything, and we have some amazing people here in this group, and I would love to hear from you. What challenges are you thinking about, and do you experience in your rural communities? What challenges are people facing to growing the workforce? So we talked a little bit about the challenges to receiving healthcare. I think we've talked tons about that in different discussions. But when we're really looking at the workforce as a solution, what are the challenges to building the workforce? Because that's kind of how we've been shifting our focus lately. We want to grow and advance the workforce, and with the workforce that we have, we want to maximize the services we provide and the care that we can provide. So if anybody feels like going off mute and telling me a little bit about workforce challenges in your region, I would love to hear it, or feel free to type in the chat.
I see
Funding,
put in the
school.
chat. Yeah, funding. Yeah, sorry. Go ahead, Mary. I don't want to interrupt you.
Oh, go ahead. No.
I was just reading the chat.
Same with me.
I see Christina puts not all providers want to work in a rural environment, which I think we all see that a lot. And those that don't always accept Medicaid, those that do don't always accept Medicaid, which is a barrier for patients in rural communities. Yes, funding, affording school, supporting a family.
Yeah, lack of dental providers. Yep, I agree with all of those. So we'll go to the next slide. I threw some of the pieces that we're finding onto here because we work directly with our tribal communities. We talk to the people in the clinics and the communities and say, what are the challenges? Why not go be a dentist? Or why don't you have more dentists or dental healthcare providers? And a big one we hear is education program locations. So I directly know several people that would love to go on and advance their education, but because of family commitments, they can't leave the town that they live in. They need to be there for their children can't move, or they're caring for elderly family members, so many reasons that they can't leave the community they're in, and the locations of the education programs would require them to do that. So that's a big one. The schedules of education programs. So if there was something offered in their community, maybe the schedule doesn't work with their work schedule. They can't quit their job. I'm going to pause and look at the chat because I see that something popped up. Okay, and in Minnesota, yeah, dental therapists. The team approach is invaluable in serving rural and urban areas. There are multiple examples of situations where a rural practice couldn't recruit an associate dentist, so hired therapists have successfully maintained services in their community. Yes, and I want to give a big thank you to all the amazing work that's been happening in Minnesota. That's Deborah, you're in Minnesota, is that right? And so yes, I see you nodding. Wonderful. Yes, we have looked to all of the work that you have done so many times. And agreed, we're experiencing some of exactly what you described. So costs of education are also a barrier, as somebody mentioned in the chat. Here's something that fascinates me a lot about the dental education systems that we have in the United States, are that the education doesn't stack and build. An example I'll give of that is that when I was a first-year dental student, a couple minutes ago, I had a few classmates that were already very highly experienced dental hygienists. They knew so much going in day one to dental school. They could provide injections, they could provide deep cleaning. They already had 2 years of education under their belt. Yet, because of the way that our education system is built, there was not an option for them to receive any advanced standing. They had to start from day one, attend every class, pay for a lot of classes that they kind of knew already, or did know already, actually backwards and forwards. And so, not everybody has the ability to spend that much time and money in education programs to advance their education. And if they don't have credit for the education they've received, it creates an additional barrier for people. And so we really are looking at ways that people can have what the education systems call stackable credits, and where their skill sets can build upon each other, so they're not having to repeat as much of what we see having to happen in our regular dental assisting, dental hygiene, and dental therapy and dentistry programs. So another big one that we'll talk about in a little bit is this variation in scope between states. That's a workforce challenge because there might be somebody who's trained to do a whole bunch of stuff. They want to be able to deliver those services, but because of state practice acts, they're limited in the services they can provide. Supervision options and requirements are also a barrier. So if somebody can do a lot of services, but they don't have a supervisor available, they may not be able to perform those services depending on the laws in that state that require certain supervision levels. So if anybody would like to add to what we're seeing, I would love to hear about it. These are the main ones that we're hearing from our communities, and these are what we're working on addressing. So we'll go to the next slide. I also want to say that, of course, we at Northwest Portland Area Indian Health Board are not the only ones looking at this workforce issue. This is national. This is every state that I have heard about is looking at dental workforce shortages. It's a nationwide issue. And this is a picture of a couple of different pages from a report that was released a few years back. It was done in cooperation between the Health Policy Institute at the ADA, American Dental Assistant Association, Hygiene Association, DNB. So this is a big group effort to release this white paper. And they looked at the workforce shortages, and then they looked at workforce strategies, retention strategies. And I thought this paper was really interesting because they talk a lot about what we are looking at and talking about. One of the main ones being growth opportunities. So people tend to stay in a profession, they said, when there are more growth opportunities and they don't feel stagnant. And so that gives that idea of buildable, stackable credits and ways to advance your career with minimal barriers. So we'll kind of reference this a little bit. But let's go to the next slide. And I will now kind of talk about the program that we're working on, because we have a really awesome framework that our tribal leaders have advised us to work with and under that has enabled some really great successes. And it's still lots of work in progress, but also some great pieces that we can share that are working. So I'll give an introduction to the Community Health Aide Program. Program started in Alaska, so we have to just give so much credit to the genius in Alaska, which is the tribal leadership and all of those working with the tribes in Alaska that recognized back in the 1950s and 60s that trying to ship in healthcare providers to provide healthcare in rural communities really wasn't a sustainable or effective solution. The solution was, and this speaks to Christina's comment about people don't always want to work in rural areas. The people that do want to work in rural areas are the people that are from the rural areas, whose families are in the rural areas, who live in the rural areas. And Alaska tribal leadership really understood that and said, the way that we're going to have effective healthcare in our communities is we're going to train it from within and have that resource available rooted in the community from the community. So that became what is called the Community Health Aide Program. The program sort of came about in the 50s and was formalized in the 1960s, originated from actually a response to the tuberculosis epidemic. But because it was so successful, it really grew. And that it was written into the Indian Healthcare Improvement Act in 1976. And in 2010, based on the great success Alaska was seeing, the national expansion of this program was authorized in the reauthorization of the Indian Healthcare Improvement Act. So while it was only a program allowed in Alaska before in 2010, it was allowed to expand nationally after 2010. So I will say it didn't happen instantly because there wasn't funding tied to it, to the national expansion. The specific policies hadn't been released. So it was a multi-year process with a lot of advocacy from tribal leadership in our area and probably many others that enabled the policy to be released, and then some funding later attached to the national expansion. And that's all happening still right now. So it's exciting to be able to talk about it because it's happening at this moment. We'll go to the next slide. some pieces that we love about the Community Health Aide Program overall, is that it really, we in public health care a lot about social determinants of health, and CHAP addresses social determinants of health. Kind of amazingly, all in one program, you can address all these social determinants. You can provide accessible education. You can make care more accessible because you have more providers in those communities. And some of the attributes about the care providers really make it more effective in that way as well. And you'll hear a little bit more about that. Ultimately, healthier communities. And the social and community context, I think, is important here because there's specialized training for all the providers within this program to have culturally responsive workforce capacity to work in a trauma-informed care with that lens and with that training. And we're seeing some social influence come out of the providers being these sort of pillars in the community and being from the community. And I have a couple of stories about that I'll share. So finally, of course, when you have people working in stable, successful healthcare careers in rural communities, you're increasing the economic stability of the communities there. So we love all these things about CHAP. We'll go to the next slide. And I will say that CHAP is a pretty broad program. It includes the medical piece of it, which is actually what's called the Community Health Aide Program, and the providers under that kind of arm of the program, and that was the original. And then later in the early 2000s, like around 2004, the dental component was added to this program in Alaska, became very successful. And very soon after that, the behavioral health aid component was added. So CHAP now in Alaska and in its national expansion includes these three sort of segments. In our region, I get to work tons on the dental piece of it, which is really fun. Also because I don't have expertise in behavioral health or community health, but I do in dental. So we'll go to the next slide. I'm going to talk just a little bit about the legal framework of this program. I mentioned that it was authorized in the Indian Healthcare Improvement Act, and prior to that, there was a legal framework for it in Alaska. The providers that work under this program are federally certified, so they don't get a state license, they get a federal certification to provide the care that they provide. And that's for lots of reasons, but one of the important reasons for that is that tribes are not state entities. They are their own nations, and they have government-to-government relationships with our United States government. And so it wouldn't be appropriate to have them work under a state oversight. It was more important for them to be working in partnership with our federal government. And I will also state for those that aren't familiar, this program is currently legally available for tribal communities, and that includes tribal clinics and IHS clinics, which there's just some differences between what those are, but they're essentially the clinics that are in tribal communities in our country. It's not yet available to urban Indian programs. I say yet because I don't know what kind of evolution will occur in the future, and there's a lot of interest for that. And in theory, it could be available more broadly, but at this time, it's only available for tribal and IHS clinics. We'll go to the next slide. I provide a couple of links here if you'd like to learn more about the legal framework. But the legal framework, or the legal details, I will say, and the rules surrounding the program are written in kind of exhaustive detail in this document called the Standards and Procedures. There are currently available on the internet 2 different versions of this document, one through the Alaska CHAP Certification Board and one through the Portland area CHAP Certification Board. So I put the links there, and there's just a picture of just what part of the table of contents for this. It's a 100 and something page document that details those 3 disciplines: the behavioral health, community health, and dental health, the overall program, rules, regulations, framework, certification process. So if you're interested in that level of detail, please feel free to go to these links and you'll find clickable spots to download the standards and procedures. We'll go to the next slide. Part of the standards and procedures has built in these academic review committees, because the training piece of this is a really big part of the program, the training and certification. And so each discipline has an academic review committee that is comprised of subject matter experts that ensure essentially the integrity of the education programs that are combined within this. So yeah, we'll kind of move on, but I'm happy to take questions if you have questions. I also know that we just have a quick hour here. I mentioned that Alaska added the dental component in 2004, and that includes 4 types of dental health aides under the framework of their program. It includes primary dental health aides, expanded function dental health aides, dental health aide hygienists, and dental health aide therapists. And I'll go into a little bit more detail about what each of those does. In case you're curious, you can also read in exhaustive detail in the standards and procedures about them, but I'll give a quick overview. And I would like to say that all of the provider types in this program do work under the supervision of a dentist. Does that mean the dentist has to be right there providing supervision? It does not. There are 3 types of supervision that are described in the program. Direct supervision, where the dentist is there approving a procedure, checking the procedure. The next is indirect supervision, where a dentist is on site but doesn't have to provide that more direct supervision. And the 3rd type of supervision is general supervision, where the dentist does not have to be on site. They can be many miles away, but they do have to be available for consultation at all times while providing the supervision. I will say that the general supervision is a really important piece of this program. It allows it to function in our rural communities. So we'll go to the next slide. So I'll reference again that Alaska has an amazing, amazing dental health aide program. And I will now focus on how we in the Northwest have looked to Alaska and have looked, I'll also say, to Minnesota, the dental therapy that's been happening there, and how we've worked with our tribal communities to develop a program that's really responding to the specific needs of our tribal communities, and how that's working out. So the next slide will give a great deal of credit to Chairman Brian Clattisby, who at the time was the chairman of the Swinomish Indian tribe. He was a great champion. He's still alive. He's no longer serving as chairman. I believe he's retired. But he's a fantastic champion for oral health for tribal communities in our region. And he famously said, "We must break the cycle of poor oral health. And while it may take a generation, we must start now." For those of you who are not familiar, tribal communities for the last several decades have really, since colonization, have experienced the greatest oral health disparities in our country. When we look at all of the demographics and we look at all of the disease rates and caries incidents, tribal communities are just experiencing some of the most severe oral health crises. Alaska described it as a crisis in the 90s and 2000s. And so it's really, really important that tribal communities are addressing this in the way that works for them, because there were many years that IHS made a lot of efforts to address. They still do. IHS does a lot of great work, but it wasn't as effective as what is needed. There was still a lot of disease. I do want to always preface this when I talk about the disparities. I always want to preface that tribal communities actually famously had some of the best oral health in the entire world, as is very well documented, all the way up until colonization. So it's really very directly related to colonization and the occurrences and the environment that they're placed in after that led to the oral health crisis they are experiencing today. So Chairman Clattisby was a great advocate for solutions that work for tribal communities, by tribal communities, for tribal communities. And under his leadership, the Swinomish tribe exercised their sovereignty, and despite a lack of a law authorizing dental therapists in Washington state, they brought the first dental therapist that was already working in Alaska down to Washington state to practice in their community. And that sort of led the way for a lot more work to occur. And so we want to give tons of credit. We'll go to the next slide. I'm not going to read this in detail, but if you want to reference it, you're welcome to. This is just a timeline showing that since 2013, this has been a great big effort and focus for our communities towards this development of dental health aide program, and also with a lot of focus on very specifically the dental therapy piece. A lot of our early years in the program from 2015 until 2022 were pretty well focused on dental therapy, and there's a reason for that I'll describe in the next slide. So when I mentioned that the Indian Healthcare Improvement Act authorized the nationalization of CHAP for tribal communities across the United States, and I mentioned that there are behavioral health aides, community health aides, and dental health aides, those three types. And within each type, there are multiple sort of levels of providers. When it was reauthorized when the Indian Healthcare Improvement Act was reauthorized and it was allowed for CHAP to expand, there was a piece that stated, except dental therapy. So all of CHAP was allowed to go through national expansion, except the dental therapy provider type, in which it stated in the Indian Healthcare Improvement Act that tribes needed the permission from the state government to incorporate that one provider type in the expansion. And because of that, a lot of effort, a lot of focus, a lot of funds were spent on getting state authorization so that the tribal communities, at least in our region, would be able to utilize all of CHAP when they did the CHAP expansion. So a lot of early years were working with coalitions on advocacy to allow for dental therapy to be a provider type that was authorized and reimbursable in our tribal communities. So this is a map that shows where dental therapy is authorized. And a big apology to Minnesota, because Minnesota has dental therapy authorized. And when I downloaded the PDF of this, for some reason, even though on the website Minnesota is red, when I made it a PDF, Minnesota turned sort of a dark gray. But so Minnesota, so there are 14 states that have dental therapy authorized in those states at this time. And there's some outline in red states. I know you are special. I have no idea why. And I couldn't even like turn it red again. I tried. I bet if I were a more savvy computer person, I could have done it, but I wasn't. So I decided I would just tell you all that I'm sorry that Minnesota is gray. So some of those states are outlined in red. Those are states that are, to my understanding, they're currently advocating for dental therapy legislation. The red and sort of pinkish states have dental therapy legislation in some form. But there's a lot of variation. So we'll go to the next slide. This is kind of a snapshot that shows sort of an idea of that variation. So there is variation across the states that have authorized dental therapy in terms of what the prerequisites are at that state level to become a dental therapist, what the supervision levels are that are allowed, what the specific scope of practice is that's allowed. And so it's not a one-size-fits-all for the various states. And even in the 3-state region where I work, there are some differences between the laws. But I thought it would be good to point that out so you knew that under the Community Health Aide Program. And so I'll kind of point to that in a couple of minutes. And I want to give the context also that dental therapy is not the only profession that has this very sort of wild variation of authorization and laws across the state. So we'll go to the next slide and I'll give you a snapshot from the dental hygiene world. This is, I will say, the dental therapy diagram that you saw from the Oral Health Workforce Research Center. I just love them. They have the coolest graphics. They give the best kind of overview information. But the dental therapy graphic was from earlier this year. This dental hygiene graphic is a little bit out of date. It's from 2019. I do hope they give an updated one soon. I know they're thinking about it. But there is just so much variation in the laws surrounding dental workforce in every single state. And it fascinates me that some states are very restrictive, some states are not restrictive. And I think it's worth taking a look at, especially when we're wanting to allow for more utilization of workforce in rural communities. So let's go to the next slide. So I would love to hear from you all, although I know that we don't have tons of time, but just a quick, maybe verbal or in the chat, to your mind, are there reasons for this crazy variation in scope, in supervision, and practice settings where people can work? Why do you think Some states really restrict scope, or some states really allow for a broad scope. Same with supervision, same with practice settings. Why would they do it? Why don't they want it?
And I know if it's okay with you, Miranda, too, I would even say we could stop our screen share and I would invite folks to come on camera if they're able to. I see some things in the chat. But if folks are able to come on camera for our community discussion, that would be great. I think I see Sarah shares a matter of whether or not state is more rural, progressive, etc. Christina's sharing that we have legislation for dental therapy in Nevada, but the landscape of providers and legislators make it difficult to recruit dental therapists. And Lynn is talking about competition. Layla's sharing that in Colorado, hygienists have a very expanded scope and it allows them to decrease barriers in access to care and provide important prevention services about supervision. Layla, if you're able, I would love to hear if you have any thoughts or pieces to share on if you know how Colorado got there, or kind of any success story pieces that you think would be helpful to folks. And if you're not able, maybe you could share that in the chat too.
Liz, while I was thinking of that, I'll ask a question. I know in Illinois, where I live, there's not always consensus, even within the dental public health community, about what the scope can be or should be, or who should regulate it and how, kind of, et cetera, and how much training should go into it, formal or informal education, et cetera. Could you share a little bit more about how or if tribal communities are more cohesive in some of that areas? Do they reach consensus in an easier way than perhaps folks outside of tribal communities? Have you seen that happen?
I can say that a couple of things. So one is I should always start by saying, if you know one tribe, you know one tribe. There's so many differences between the different tribes. But in terms of the dental workforce legislation, specifically dental therapy, because that's been more recent, there was a lot of consensus in terms of working together and on the same coalition. On one end, there were the tribes like Swinomish that were just giant advocates. And then on the other end, there were a couple of tribes that said, dental therapy might not be the solution we want right now, but in terms of being in solidarity with our tribal communities, we're going to advocate for this because we know that you as a tribe know what works for you. And if this is what you want, you should be allowed to have it. There shouldn't be a law at the state level getting in your way. And so it just allows for, if there's a law authorizing something, it doesn't mean everybody has it or has to have it. It means it gives the option for those communities that believe it's right for them. And so based on that kind of concept, the tribes had in general been very cohesive in those ways for advocating for each other.
And are there practices that you know of that we could borrow from how tribal communities have worked together, and that consensus building or relationship building that could apply to folks outside of tribal communities? I mean, that sounds really lovely and beautiful. And I know that there are a lot of folks outside of tribal communities, a lot of special interests outside of tribal communities that impact our ability to sometimes be cohesive and unified in this approach.
Sure. I mean, in my limited experience, that coalition building is such a huge piece. Having so many partners, even with the tribal communities, it wasn't just tribal communities that made legislation happen. It was being part of a really broad coalition, lots of partners that, even if there are slight variations in preferences or differences, could come together and say, okay, let's get behind a common goal to increase access to dental care, ensure safety and quality of dental care? How can we make sure all of those priorities are met? And I was able to attend a lot of meetings of that type between 2019 and 2023. And even now, as Washington is going through its rules process for its most recent law. And it's just such a cool experience to hear that kind of productive conversation, and sort of small pieces of agree to disagree on this point. How can we find a way that this works for everybody? So my short answer is just really broad and productive coalitions. That was my experience with what worked in Oregon, Washington, and Idaho.
I think I'm really seeing that reflected in what folks are sharing in the chat as well. Layla was sharing that a very strong dental hygienist association can be helpful. Deb is talking about really getting folks kind of coalesced and together to kind of overcome some of these barriers. And I think Jessica is really leading to that as well with the comment about there can be some differing opinions on licensure and the federal and the state pieces, and so really getting folks connected and those messages pulled together in that coalition building. I really feel like that addresses all of these pieces that everyone's sharing.
Yes, and I think good information too, because when I talk to folks that maybe have concerns, I think it's always, I want to give the benefit of the doubt and say it's valid concerns. People want to make sure that the public is safe, that care is high quality, that people have good training to do what they are allowed to do. And so I would say that when I hear people with really like kind of intense concerns, often I hear that they either have heard misinformation or just don't have a lot of information. And we're scared of things that we don't feel informed about. So providing that information is always really helpful. And I want to give a big thank you to Community Catalyst and parishes in here, because I know they're working to get good information out in the world, and the American Dental Therapy Association and so many other organizations. But even on the hygienist piece, which, hygiene is not a very controversial profession now, it absolutely was in the 1920s. It was hugely controversial, just like dental therapy is now. But dental hygiene, even with broadening scope of practice for hygienists, is so controversial in some states and less in others. So it's just a very interesting topic. But I want to make sure I have time to share some stories with you. So is it okay if we jump back into a couple of my slides?
Absolutely. Thank you.
And thanks everybody for contributing, because I love these topics. So I wanted to point out for the dental therapy topic that in the United States right now, there are 2 institutions that have accredited dental therapy education programs that are designed specifically to meet the requirements of the Community Health Aide Program standards and procedures. So there is there are a couple of other dental therapy education programs in Minnesota. One is accredited by CODA, and one I think is working on it, but I don't know that they are written specifically to the CHAP requirements. These 2 programs, one in Alaska, one in Washington State, are written specifically to ensure that graduates will be eligible for CHAP certification. And so there's just contact information if you'd like to learn more. They both have websites, great programs. Alaska's program was CODA accredited in 2020, I believe the first one in the nation, and Skagit Valley's colleges was accredited in 2022. So now I'll focus for a while on very specifically the program that we're working on at the Northwest Portland Area Indian Health Board. Originally, the program that I work under was called the Native Dental Therapy Initiative because there was so much focus on dental therapy policy and working with tribes on that. That began in 2015. I came on board to it in 2019. And then after a lot of progress was made on the dental therapy piece, and as you know, the education program that was developed in partnership with Skagit Valley College and Swinomish Tribe was already CODA accredited by 2022. There was a lot of interest from the tribes in broadening. They said, okay, dental therapy, check, we have that option now. What about the rest of dental under the Community Health Aide Program? We want to see all of that because there's a lot of value in all the parts of the dental Health Aide Program, not just dental therapy. So in 2022, we brought in the program. We were able to get some funding to do that work, and we renamed to be the Dental Health Aide Program to incorporate all of the types of dental health aides in the work. So we'll go to the next slide. And I just want to share a little bit about our process. And I already told you that all of our work is directed by the tribes that we work for. But it's not just that direction that tells us what to do. We also seek a lot of input from the clinics that we work with, the community overall, and our partners. And so we conducted a dental clinics assessment, talking to the staff and leadership at the various dental clinics to say, what are your staffing challenges? What are your overall clinic challenges? We developed an advisory work group that continues to meet. Anybody can come to those advisory work groups. It's especially for the people in our region that work with tribal communities in our region, but any tribal member, anybody that has any interest in the topic can come and provide input as we talk about progress with program development. And we take all that input very seriously. And then because it's important to our rural communities to be able to get college credit for the learning that occurs, we partnered with colleges. And so there was a feasibility study in 2018 that led to the partnership with Skagit Valley College to develop the dental therapy education program, and another feasibility study that led to a college partnership for our primary dental health aid work. That college, I don't want to be a spoiler, but because it's a relatively new partnership, is with Salish Kootenai College in Montana. They have a CODA accredited dental assisting program, and they have just a fantastic dental program overall, and we're excited to be partners with them on this work. So we'll go to the next slide. A little bit about that assessment of the dental clinics. We called it the Dental Health Aide CHAP analysis. And what we heard from the dental clinics was this summary that is probably not surprising to any of you, that they had challenges with recruitment and retention, they had staffing shortages, they wanted to provide community outreach to bring care where people are, but they didn't have the staffing that would allow them to do it. And sometimes their providers were limited on the scope that they could provide, and they wanted to add to their scope, but there wasn't an easy way to do that. And they just maybe had capacity or didn't have capacity to train providers or provide additional support for their staff to have career advancement opportunities. So we'll go to the next slide. So based on all that, and then with the convening of our advisory work groups, that led us to where we are now. And I just wanted this extra slide to give a shout out to our advisory work group, who takes their lunch breaks, sometimes monthly, sometimes quarterly, depending on schedules, and provides a ton of input. And it also allows us a chance to be really transparent to our tribal communities about where we are in the process, what challenges we're facing, and how we're considering our planning, and what they should know about that so that they have opportunities to provide input. And so we just love our advisory work groups. We have them for dental, behavioral, community health, even for our overall board and our CHR work. We have so many great people that contribute to the work in this way, and they don't get enough recognition. So we'll go to the next slide. And a little bit about the dental piece. I kind of wasn't sure about where to put this detail, but the aides, the level 1 of that does a lot of outreach, motivational interviewing, OHI, fluoride. And then the level 2 is where it brings in skills like dental assisting. It actually brings in prophy, adult prophy, and radiology and sealants. So there's some extra levels there. All of this can be trained under this community health aid program in the tribal community. They don't have to go anywhere. It's in collaboration with the clinic. The next type is expanded function dental health aides. If you're familiar with the expanded function dental assistants under the Indian Health Service, it's in alignment with those levels, where they are trained to either do simple cleanings or fill cavities. And dental health aide hygienist actually is often, I want to say it's a hygienist that you're familiar with, but depending on what state you live in, as you heard, the hygienist role that you're familiar with could be very different between states. And so the dental health aid program allows for sort of a unifying in scope of practice, and allows for tribal communities that are in a state that might be more restrictive to add more duties for their dental hygienists because it functions outside the limitations of the state law and state practice act. So it's sort of like a hygienist plus. And then the dental therapist level is the dental health aide therapist. The HA in the middle tells you that it's part of the Community Health Aide Program, but it's still a dental therapist. And they are the same scope of practice that a dental therapist is, but because that varies, it's all one unified scope in the dental health aide program. So they can take out cavities, they can clean out cavities and fill them. They can do simple extractions. They can do your exams and diagnoses. And that's a really big help for our rural communities. So we'll go to the next slide. You heard me mention supervision levels, and part of that importance of the general supervision level is that in our tribal communities, there is a lot of desire to bring dental care everywhere. Some of our communities have it in schools, or there are dental health aides that work in hospital settings in Alaska, or that can do home visits or work in the prenatal department to ensure that people are getting their prenatal dental components of their care. We just love all of the components of outreach, and I'm guessing you all do too, because this is a dental public health group. We'll go to the next slide. One of the questions I get a lot from people unfamiliar with CHAP is, what's the difference between a dental assistant and a dental health aide or primary dental health aide? And it's a great question because there's a lot of overlap. They're all providing great care, but the value of the dental health aide program is that it allows for a framework and a program for training in the community. They don't have to go anywhere, but it's not just on the job training. It's a very structured program that incorporates really important things that anybody in healthcare should know, but including trauma-informed care and cultural relevance. And the next piece that I love about it is that when working under the dental health aide program with a federal certification, many of the procedures with the provider types can be done under general supervision. So a dental health aide can work when there's not a dentist present, but the dentist is available for consultation. So they can go do those home visits or work in school settings or whatever is needed in the community. And as you heard me mention, they are not limited by the state practice laws. So I have a whole presentation where I talk just about the various limitations in our states of the state practice laws, but we don't have time for all of it today. What I will say, though, is that when you're not as limited in this way, you can learn to do something, add it to your scope, and be certified to do it and provide that service to your community, which sounds very straightforward. And I think that's the way it should be. If you have education and experience doing a procedure, and you're safe doing it, and you have a supervision that provides those parameters, why not provide that service to people who need the service? And so that it provides a structure for that and a legal framework for that. So we'll go to the next slide. I have a couple of slides that just sort of give you a snapshot of the hours involved in the training for the primary dental health aide 1 and the primary dental health aide 2. So to show you that there is a virtual didactic component, so that allows it to be delivered virtually, and much of it in an asynchronous fashion, which allows for more schedule flexibility. And then there, of course, is a lab and clinical component, because you can't just learn dental workforce skills in a virtual environment. So there is a partnership with the tribal communities clinic to work on these skills and show competency. It's all a competency-based program. And of course, there's basic life support, and the preceptorship is that built-in practice time with competencies as a required part of it. The next slide, go ahead to, is the primary dental health aide 2. Those are the skills that are taught. A primary dental health aide 2 has to learn at least one of these skills and could learn up to all 5 of them. And when they learn it and they show competency and they get certified in the skill, they can provide that skill to their community, even in a general supervision environment, which allows for broader access to care. And the next slide, we just have a few minutes. So I threw in at the end here some stories that I just love to share. So the dental health aide program, you've heard me say some of the benefits, and this is why we love it, is it does provide for that community-based education. And so this is a picture of Jason Meekum, and these guys are at the Lower Elwha Tribes Clinic, where at the time Jason was working, he's a Cocoa tribal member and his tribe was building their clinic. And so he has since moved down to his tribe to work in their own clinic. But at the time, he's a dental therapist that was trained in Alaska. And he came to work at this clinic, and I was visiting, and I said, hey guys, can you show me what motivational interviewing looks like so I can take a picture and put it? So this is supposed to be a motivational interviewing picture, but what it really is, and I didn't know at the time, is it's a picture of Nicholas Running Wolf. Nick Running Wolf is sitting in the chair. He was a dental assistant at the time. And by working with Jason, he had always wanted to advance his career, but he was caring for family members. He couldn't leave the community. And by working with Jason, he learned about this program and he said, I'm going to do what you're doing. And now he is very near to graduating as a dental therapist because there, since then, was a dental therapy program added close to home, and he was able to attend. And so he was able through the dental health aide program to advance his career. And at the time, I just thought, oh, well, Nick's awesome. He's a dental assistant. He's posing as a patient. No, he's now going to be a provider because he saw this role model. He knew about the accessibility to education, and now he's advanced. And he's fantastic. I hope you get a chance to meet him someday. Same with all of these guys. So I have a few more pictures to show you with stories. This is Roz Ferry. Her name is Rochelle. She goes by Roz. She was one of the very first dental therapists in Alaska. She is from Alaska, and she has a story she tells about how she lost one of her front teeth from a trauma as a teenager, how it really deeply affected her, how she really cared about dental, but she never, ever saw herself working as a dentist. That just seemed like way too big of a leap. She was from a rural Alaskan community. That was never going to happen. And then she learned about an option to become a dental therapist. It seemed much more attainable. It wasn't requiring 8 years of school. And so she actually raised her hand and volunteered to be one of the first that was sent to New Zealand for training. She went all the way to New Zealand, came back in 2006, and has been serving communities as a dental therapist ever since, and she's fabulous. So it lets you advance your career, without huge barriers. And continuity of care is such a big one. So you probably know that rural communities face a lot of situations where somebody comes because of a loan repayment program or because it just sounds like an adventure, and they work for a little while in the community and then they leave. And then when they leave, maybe the community has nobody providing care for a while. Marissa is a dental therapist that works in Oregon. She works in a rural clinic. They have been through some insane number of dentists in the last few years. She graduated in 2018 from the dental therapy program in Alaska. She's been working in her community since 2018. She's had, I forget the number. It's somewhere close to 10 supervising dentists in that time, the dentists that have cycled through her clinic, and in between there's nobody. If Marissa were not in her clinic, her patients wouldn't have a care provider in their community. Or when they do, it's a different one each time. They don't get to build that relationship. But she's been there solidly since 2018. In this picture, she's providing a very first dental checkup to this little one. And I just have so much optimism for the oral health in her community because she is there doing that work. And I was proud to be the one that took that picture. So another thing we love about it is extending that clinical reach. This is Angela. She's a dental therapist that works with the Lummi tribe. She's a Lummi tribal member. And in this picture, she's working in their school-based program. So Angela works a couple of days a week in their main clinic, and 3 days a week she goes to the school clinic. They have a school-based clinic with a dental chair. And I went with her to that clinic not too long ago just to take a tour, and she just lights up when she gets there. They don't have capacity to have a dentist out of the clinic going to the school-based clinic, but Angela sort of she doesn't own the clinic, but I want to say she owns the clinic because she just lights up. It's her spot. She loves working with the children in her community. And I don't think they'd be operating that clinic to the extent that they are without her. So we'll go to the next slide. I mentioned the disparities in oral health status for American Indian and Alaska Natives. There's an even greater disparity in representation in healthcare careers. And, it's like less than 1% of dentists are American Indian and Alaska Native. Same with doctors. This picture is some of our dental therapy graduates. It's the graduates that came from the Northwest and graduated from the Alaska Dental Therapy Program in 2019. They're all American Indian, Alaska Native women. They're wonderful. And so we love seeing this increase in our AIA and healthcare providers from this program. We'll go to the next slide. And these guys are inspiring the future. So you heard that Jason in that clinic inspired Nick to advance his career. But what's really cool is the kiddos that are seeing all of this. And this picture is Ariel. She is a Colville tribal member. And during the pandemic, when the clinics all closed for a little bit, the dental therapists made videos to put on social media to say, don't forget your oral health. And this is a video of her with her daughter. She's showing people, I just took a snapshot of it. She's showing people different ways to get kids to open their mouth and let you see their teeth. But what I really see happening is that her daughter has this amazing role model of a mother who's a healthcare provider, who's an icon in the community. And she is going to grow up knowing that healthcare careers are absolutely within her possibilities for her future. So I just can't help but smile when I talk about these guys. I love them so much. And we're at 12 o'clock and luckily I'm all done and I'll hand it back to Liz.
Thank you so much. Those stories were so wonderful. So I wanted to make sure we took an extra minute and got those all in. I hope everyone will join me in giving a big thank you to Miranda. That was a fantastic presentation. We are thrilled that not only are we sharing it live here today, but as I said at the top of the call, we're recording. So we will be posting these materials to our website as well. We also said that CEUs are available for attending today's session. Rahel is going to pop that link in the chat. Thank you, Rahel. We have about 48 hours to complete that evaluation and CEU request. We'll send out a reminder via email as well, but if you complete that, we'll get those processed for you next week. Attached to that CEU link is also an evaluation. If you aren't interested in a CEU but are interested in taking the evaluation, please do so. It's incredibly helpful for us to ensure that we're delivering good programming that's as useful as possible. If you have any questions for us or for Miranda about this content, please let us know. We have our email here, our website, our contact information is posted there as well. And just thank you everyone for attending, for your engagement. It was a wonderful discussion. And please look out for materials and share with your broader networks once they're posted. And thank you again, Miranda. Take care, everyone. Have a great day.
Thank you so much. Good to be here.